Hello to this brand new Master Series session. The 27th of July each year has been declared by the International Federation of Head and Neck Oncology Societies as World Head and Neck Cancer Day. There are over 5 lakh cases and more than 2 lakh head and neck cancer-related deaths globally each year. With greater awareness and the signs and symptoms to look out for, some of these cases are preventable. Oral and pharyngeal cancer is the sixth most common malignancy reported worldwide and one with high mortality ratios among all malignancies. To talk about oral cancer and more specifically about buccal and alveolar cancers on this World Head and Neck Cancer Day, we at DocPlexus would like to welcome you all to today's special webinar on routes of spread and surgical approaches in buccal and alveolar cancers by eminent oncologist Dr. Narayana Subramaniam. Dr. Narayana Subramaniam is a Bengaluru-based surgeon specializing in head and neck oncology and reconstructive surgery. He offers a whole range of treatment to patients with head and neck cancer, including innovative treatments like 3D virtually planned dental implant-guided reconstruction of the jawbone and facial nerve reconstruction. With a team of experts, he is able to offer high-quality, affordable surgical and non-surgical care to patients with disorders of the head and neck focused on quality of life. In addition to the latest surgical treatment, he ensures that the patients receive high-quality dental care, speech and swallowing therapy, nutritional support, physical rehabilitation, and psycho-oncology care. He is also a clinician scientist focused on improvements in existing head and neck cancer treatment. He is an investigator on multiple ongoing clinical trials and research which offer innovative treatment options to patients with head and neck cancer. Through his collaboration with scientists and engineers, he is involved in the development of low-cost, technology-driven devices for cancer diagnosis and treatment. He has a passion for community outreach in oncology and public health, specifically targeting low-income households. With his unique insight to the confluence of medicine, technology, social impact, and entrepreneurship, he is the Bengaluru chair of the All India Managers Association Young Leaders Council and the oncology mentor for GE Indian Edison Accelerator Program Cohort 3. He also regularly contributes articles on health for the general public. It's an absolute honor to have you with us today, sir. You may please share your screen and begin your presentation.
Hi, everybody. Good evening. My name is Dr. Narayana Subramaniam. I'm a head and neck oncologist at Shankara Cancer Hospital, Bangalore. So at the outset, thank you, DocPlexus, for giving me this session. I am basically a general surgeon by training, and I've done my MCH in head and neck oncology. I've also done some higher training in reconstructive surgery as well. One of my interests is oral cancer, especially locally advanced oral cancer. It's definitely the scourge of the Indian subcontinent, but it is a disease that if we treat well surgically, patients survive for long periods of time. So unfortunately for locally advanced oral cancer, we have no non-surgical treatment available. Therefore, learning how to manage these patients surgically, how to pick the right approach for the right patient, how to clear these tumors well, and making sure that they're disease-free can result in patients living long and meaningful lives. So I'm going to start off with my presentation. I'll just share my screen. Yep. So this is my presentation today. It's called Roots of Spread and Surgical Approaches in Buccal and Alveolar Cancers. So it's a bit of a technical presentation. It's more for surgeons and people who deal with this kind of cancer. So jumping into it. So this is the outline. So we're going to start off with an introduction to alveolar and buccal cancers in the Indian context and why they are distinct from those seen elsewhere in the world and why we are talking about this in such detail. Then we'll go into the surgical anatomy of these cancers. Then we'll cover the routes of spread, basically within the bone and soft tissue in these kind of cancers, why they're important, why we have to understand them very well before we venture into any surgical resection. Then we'll talk about surgical considerations. So when we have a patient with one of these cancers, especially a locally advanced cancer, what do we have to consider before we plan their surgery, before we put a scalpel on them? And then finally, what are some of the concepts in margins and three-dimensional clearance and why exactly they're important? So starting off with the introduction, so buccal and alveolar cancers in Southeast Asia are definitely a distinct entity. So what I mean by that is, in addition to them being the leading form of oral cancer in Southeast Asia, this is primarily because of chewing tobacco. The rest of the world, the Western world, especially tongue cancers, oral tongue cancers are the most common. But because of Southeast Asians having this habit of chewing tobacco, primarily in India, also in other parts of this Indian subcontinent like Pakistan, Bangladesh, Sri Lanka, and also parts of Taiwan as well, buccal and alveolar cancers are very, very common. So they are some of the most common cancers that we deal with. So epidemiologically, also they're distinct in Southeast Asia. The reason for this is because it's not just chewing tobacco that these patients are exposed to. They also use areca nut. They use a lot of other co-carcinogens like slake lime, betel nut, and multiple co-carcinogens. So as a result, there have been groups from papers from several groups, including ours, that show that oral cancer in the Indian population appears almost 10 years earlier than it does in the West. So the median age at presentation for oral cancer in the Indian subcontinent is 55, whereas it's 65 in the rest of the world. And by the rest of the world, I mean the US, Canada, Australia, and Europe. The reason why we think this happens is because of the fact that, of course, tobacco exposure is early and it's extensive. We are not quite sure how to quantify chewed tobacco the same way that we quantify cigarettes with pack years. And also, it's likely that multiple co-carcinogens interact with each other in order to produce cancer early. So moving on to why they're surgically distinct and why I'm going to be talking about them in such detail. So unlike alveolar cancers seen elsewhere without chewing tobacco, the ones that are associated with smoking or without habits, sometimes people have ill-fitting dentures or chronic trauma, right? So these often cause early and extensive soft tissue involvement, right? So what I mean by that is these tumors often have skin involvement. They often have paramandibular involvement, right? So unlike the alveolar and buccal cancer seen elsewhere, we end up having extensive disease, often with nodal disease presenting early. These patients with chewing tobacco also often have oral submucous fibrosis. So they have trismus, they have difficulty opening the mouth. So that makes it difficult to assess the lesion. It also makes it difficult to surgically access it. So your access for removing the tumor also is difficult. Many of them have skin involvement. So the skin involvement can be contiguous if it's on the free surface of the cheek, or it may be over the alveolus. The epicenter of these lesions is often very hard to identify. So if you get a patient with a T4 oral cancer, it's quite common that you may have maxillary involvement, buccal mucosa involvement, lower alveolar involvement, infratemporal fossa involvement. You're not sure where exactly the cancer started and where it's going. So unless we understand this, it's very difficult to plan our resection and to get a complete resection. And lastly, we have a lot of infratemporal fossa involvement. So again, in these chewing tobacco-related cancers, we have a lot of T4B cancers. Now, the NCCN says by definition that these are unresectable, that they cannot be removed completely, but there's a lot of data coming out from Asia that has come out, a lot more data in the last few years that shows that selected patients with T4B cancers can be treated successfully. Most importantly, R0 resection forms the cornerstone for these cancers. So these are not cancers that are treated well with radical radiotherapy, probably because of the close proximity to bone. There is interference with the transmission of radiotherapy, more likely between the air-bone soft tissue interface, and also they end up with osteoradionecrosis. Non-surgical treatment is vastly inferior. So now moving on to the surgical anatomy of these cancers. So now, although maxilla, mandible, buccal mucosa, and retromolar trigone are all described as distinct subsets, often they're contiguous in advanced cancers. So like I said, identifying the epicenter is difficult. Very often you have to go by symptomatology. If the first time you see a patient is with an advanced cancer, you have to ask them how exactly the tumor, how the symptoms started, whether it was loosening of teeth in the upper jaw or lower jaw, whether it started off with trismus, whether it started off as bleeding gums. All of those things are very, very important because that helps us plan our resection. Another issue is that these are often in very close proximity to the skin. Now, if you need to get an adequate margin, very often we have to sacrifice the skin in these patients. As I'll discuss later, I'll show you some scans. You'll understand that the distance from the tumor to the skin is very little in these patients, especially if they don't have a very thick cheek. If they're thin patients, like many of our Indian patients are, the dimensions of the cheek dictate the fact that we don't really have much of a clear margin if we don't take the skin in some of these tumors. Also, they can involve the infratemporal fossa early, resulting in upstaging. So we have a lot of T4B cancers. Even if they involve the masseter, for example, they are considered T4B. It's also important to understand the concentric layers of tissue in these. I think surgically what helps me personally is trying to understand the patient like an onion. So you understand, you consider the center of the onion, the tumor, you understand all of the layers that you need to cut through in order to remove the tumor completely, and also which layers you sacrifice and which you leave behind on the patient. You have to understand the barriers to tumor spread and understand what is adequate clearance. So this is the anatomy of the buccal mucosa. We've all seen it. I'm just going to talk very specifically about a few things, make some points. So you can see a cross section of the buccal mucosa here. So this is the maxilla, this is the mandible. This is basically the attachment of the buccal mucosa, which is continuous with the mucoperiosteum of the gums, the alveolar mucosa. So if you look at this, the upper and the lower gingivobuccal sulci have mucoperiosteal attachments on the free edge, upper free and the lower free edge of the bone. So this is very, very important. So what happens is in gingivobuccal sulcus cancers, which are called the Indian oral cancers, patients generally store quid, which is a combination of tobacco, betel leaf, areca nut in these areas, right? So as a result, there is quite a bit of soft tissue involvement here. So when there's soft tissue involvement here, very often what happens is, in order to clear these tumors, you may have to sacrifice bone, because even if you do not have bone involvement, the bone is a reasonably good barrier to tumor spread. When the soft tissue involved is up here, the principle here is that you have to sacrifice the bone and the mucosa at the same level. Because if you peel this soft tissue off of the bone, this margin is going to be positive and you'll be leaving microscopic disease behind there, and the patient is going to recur very quickly. Another point here is that the buccinator, if you see here represented through this line, is attached to the maxilla and the mandible. So it is like a diaphragm that helps in facial expression. It helps in puffing of the cheek. So this is another relative barrier to tumor spread. It's useful as a barrier only in early tumors, quite superficial tumors. So it provides some resistance to tumor spread. So you can use that as the deep margin of your resection in very superficial tumors. Another important thing is that the dentate mandible is relatively resistant to tumor spread. So there is a tight mucoperiosteal insertion of the sulcus, of the gingivobuccal sulci. So this buccal mucosa is contiguous with the periosteum of the mandible, and that's attached quite adherent, it's quite tight, and it is resistant to tumor spread as long as the patient is dentate. As long as there's a tooth there, the periodontal ligament or membrane is intact, it's quite resistant. So as a result, in patients who are dentate, in patients who have oral cancer arising from the sulci. Since this is a barrier, very often there is soft tissue involvement. So the tumor tends to spread either along the mandible or away from the mandible rather than through the mandible. Now, these are the mandible attachments. So we all know the anatomy of the mandible, so I'm not going to go into the basics. But here, what we need to remember is that the mandible is a hard cortical bone. So the hard cortical bone and the periosteum are both resistant to tumor spread, right? So the tumor has a difficult time breaching these when they're intact. But it's much more important for these kind of cancers to understand the soft tissue attachments of the mandible. So the soft tissue attachments of the mandible are more contiguous for tumor spread, more susceptible, to tumor spread rather than the hard mandible cortical bone or the periosteum. So very often what happens is the tumor tracks along these soft tissue attachments. So when you're resecting them, you need to resect these attachments completely and try to understand that you need to go one layer beyond them. So on the inner aspect, you have the mylohyoid, which attaches on the mylohyoid line. At the bottom of the central arch, you have the digastric, you have the medial pterygoid, which is on the inner aspect that originates on the inner aspect of the mandible and goes onto the pterygoid plate. And you have the temporalis insertion onto the coronoid process. The lateral pterygoid is inserted on the condyle. So these are all the soft tissue attachments. Very often in this area, when you have tumors, you see tumors spreading along these surfaces or into this muscle rather than through the bone. So you have to look at each of these muscles individually, understand whether they're involved or not, and how you're going to remove the tumor. This is the mentalis, right, which is on the outer aspect of the central arch of the mandible. It can be involved sometimes. If the alveolus is eroded, the mentalis can be involved, or you can have spread across the alveolar arch if the patient is edentulous. This is the buccinator attachment. So the advanced tumors definitely go through the buccinator, and you have the masseter. So comparatively, the masseter is a very strong and tough muscle. It's thick, it's quite fibrous, therefore resistant to tumor spread. So it may spread partially into the masseter, but the masseter and the parotid interface, the parotidomasseteric fascia, that's again quite tight and fibrous and does not allow tumor to spread very easily. So as a result, when you have soft tissue involvement, very often we sacrifice the bone even when there's no bone involvement because of the soft tissue involvement. So the principle here is that you need to remove the bone and the soft tissue at the same level, right? Because otherwise you might leave occult disease behind on the bone and the patient will recur there. It's a positive margin, which is associated with a very, very poor survival. Another important concept here is paramandibular spread. So if you have disease on the outer aspect, if you have disease on the outer aspect, on the buccal aspect of the mandible, so if you have sulcus involvement, if there's soft tissue involvement here along the interface between the alveolus and the cheek, you may have to sacrifice the bone here, unfortunately, because if you do not, you will be leaving a positive soft tissue margin here. So as a result, sometimes even with very small tumors, the dimensions on the CT or the MRI might be very small, but our resection specimens end up very large because of the complex anatomy. So this is the infratemporal fossa, as we all know, very important. So this lies between the ramus laterally and the lateral pterygoid plate medially. Superiorly, we have the greater wing of sphenoid, and you have the carotid sheath posteriorly. So for buccal cancers and for advanced alveolar cancers, this is a place where the tumor can spread. This is anatomically a very complex space. It's a large potential space. You have neurovascular contents. There are also the muscles of mastication, and you have loose areolar tissue. So the place where the infratemporal fossa can be involved the earliest is along the inner aspect of the mandible, along the medial pterygoid muscle. So very often, if we have a retromolar trigone or a buccal cancer, it can spread across the alveolus without eroding the bone to involve the medial pterygoid. So this soft tissue spread is something that we need to look out for, because if there's medial pterygoid involvement and you cut the bone here, you leave the medial pterygoid back on the patient, you're going to end up with a positive cut margin. So understanding when the infratemporal fossa is involved is important. Similarly, if you are looking at masseter involvement can also occur sometimes without bone involvement, right? So the outer aspect of the mandible, you can have the masseter involved. You have to understand when to remove that masseter and not leave any disease behind. So in most cases, supranotch disease is not considered completely resectable. So if you have infranotch, this is the sigmoid notch. So if you have disease extending below this notch, there's a good chance that you can get a full clearance. Above that, it's not absolutely unresectable, but it's a relative contraindication. So very selected patients, very selected surgeons. So this is some imaging, which I'll take you through just to illustrate some of the points I was talking about. So here, this is the floor of the mouth and the alveolus. So you have the inner aspect of the alveolus, you have the genioglossus, you have the mylohyoid, hyoglossus, and the palatine tonsil. So now you can imagine that if you have a retromolar trigone cancer, right, or if you have a buccal cancer sitting in this area, how many structures it can involve, right? So even without eroding the alveolus, there is a chance that it can go along the tonsillolingual sulcus and end up along the palatine tonsil area. So very often these advanced cancers can go up to the tonsillar pillar. They can involve the oropharynx extensively. This is a surprise sometimes when the patient has no mouth opening, and you can only see once you put the patient under anesthesia that the mucosal extension is quite a bit. So that is something that you have to be aware of and something you have to look at very carefully on the imaging. So do not venture into surgery unless you've studied the scans and you discuss them in detail with a good radiologist, because you may end up in serious trouble. Because very often we have to make premeditated bone cuts when the patient has absolute trismus. They're unable to open their mouth. Some patients, we're lucky, you give them anesthesia. It's a kind of inflammatory trismus because of pain. Mouth opens up. Some of them, even after anesthesia, mouth doesn't open up. So then the only way we can see the tumor is after we actually cut bone. We usually cut the mandible and have a look. So if you cut the mandible and have a look and see that there's extensive oropharyngeal involvement, the uvula is involved, soft palate, then probably not a patient you should have been operating in the first place. So this again shows us, this is the retromolar trigone. Okay, these are the alveolus, this is the tonsil. So these tumors very often can track along the retromolar trigone without breaching the alveolar bone in order to involve the medial pterygoid. And when they involve the medial pterygoid, they can track up into the infratemporal fossa. Similarly here, it is possible to have masseter involvement when you have tumor on either side of the mandible. You have tumor on the inner aspect, the lingual aspect, and the buccal aspect. Sometimes you can have tumor involvement on both sides without alveolar erosion, not that uncommon. This is the buccinator, which you can see is a thin line. It's useful as a landmark only in very early cancers where you can take it as a deep margin. Again, extensive cancers can involve the superior constrictor. As they reach the tonsillar pillar, they go deeper. So these are cancers you need to be very concerned about whether you're going to be able to resect them fully. Because if you take the superior constrictor as a margin, all you have is a the fat pad on top of the common carotid artery. So are you actually going to be able to clear these or not is a question mark. So this is a coronal section where we're looking at the tongue, we're looking at the alveolus and the floor of mouth. So the reason why I've chosen these pictures is so that we can look at spread on either side of the alveolus, right? So if you have an alveolar cancer, it is possible to spread onto the floor of the mouth. You can have the ventral tongue involved. So sometimes, especially if it's a central arch floor of mouth, you may end up sacrificing quite a bit of tongue. It's important to look for that, prepare the patient for that. You can definitely have involvement of the mylohyoid muscle. If it's not involved, then it's useful sometimes to take this as a margin. So after you've cut the alveolus, you traction the mandible outside and you detach this as far as possible as a soft tissue margin. So how we maximize margins in all these cases, I'll come to at the end. But if you look at, the paramandibular spread, again, is another concern. So in a patient with a gingival-buccal sulcus cancer, there can be spread along the edge of the mandible. So if you have disease going beyond the point at which you can do a marginal mandibulectomy, and what I mean is that you cannot save 1 centimeter of cortical bone here, then you will end up having to do a segmental mandibulectomy. So very, very important to look at all of these things carefully. Again, soft palate involvement, you can have submucosal involvement in some of these big buccal cancers. So you should not miss that out. So now roots have spread through the bone, we all know, using the mandible as our scenario, came from Brown. So you can have tumors spreading along the occlusal root. You can have tumors spreading along the periodontal membrane, as you all know. Very often, the root of spread into the bone is along the attached gingiva. So that is the most important route of spread for our gingiva buccal sulcus cancers. You can have involvement through the mental foramen. You can have involvement along the mandibular foramen. You can have abutment of the lower mandible in the neck if you have a large lymph node that erodes the mandible or is stuck to the periosteum. And you can have cortical defects in the edentulous ridge. So it's always important that if you're looking at a patient with a buccal or an alveolar cancer, you look at their dentition, especially in the region of the tumor. Very often you will have patients whose first symptom is that they had loosening of teeth. And this is typical of an alveolar cancer, a tumor that starts within the bone. And as a result, there's destruction of the periodontal membrane, ligaments, loosening of the teeth, and the teeth fall out spontaneously from the sockets. Very different than a gingival-buccal sulcus cancer or a buccal cancer, where it starts off in the free edge of the cheek, involves the alveolus at the point of maximum abutment, and then finally erosion and loss of teeth. The additional considerations for all these patients is the dental status. So if you have a patient who is edentulous, the chance of the adjacent tumor going into the bone is much more, especially if the height of the bone is less, because obviously we know that that recedes when there are no teeth. Trismus is again a very, very important consideration. Now, if you have a patient with absolute trismus and it doesn't improve after inducing after general anesthesia, it is likely that you will have to do a segmental mandibulectomy to improve mouth opening. So you can get away with as little of a segmental mandibulectomy as possible. So what I mean by that is if you have soft tissue involvement, almost involving one side of the mandible, you can do one area of segmental and the rest can be like a marginal mandibulectomy, what we call an L-shaped resection. So that way you avoid the morbidity of a large segment of a segmental mandibulectomy. Of course, when tumor is not involving the mandible, I'm speaking only in terms of a margin. So trismus, you have to plan where you're going to remove the bone, how you're going to remove the bone. Again, prior irradiation changes the nature of the tissue. The principles that we follow with respect to tumor barriers, periosteum, things like that, all go out the window. And our ability to do a safe marginal mandibulectomy in an irradiated mandible is also less. Patient might have osteoradionecrosis, it might fracture. So very often we are hesitant to do a marginal mandibulectomy in an irradiated patient, and we may end up removing more bone for a safe margin. Remember, these are margins in the bone we find out only 10 to 14 days later after decalcification, even though there are ways that have been described like scooping out some marrow tissue and sending it for frozen section. None of them have been shown very reliable. So we need to make sure that on table, we're quite sure about whether we've got bony clearance or not. Now, roots have spread. We're talking about soft tissue. We have some relative barriers to tumor spread. So the parotid-mesenteric fascia, like I mentioned, is quite thick. It's almost like a fibrous band. So usually the tumor doesn't spread into that. If you have tumors that are involving the parotid gland per se, they're usually very advanced tumors, usually very aggressive tumors. The masseter also is quite a thick, resistant muscle. So unlike the medial pterygoid or the buccinator, tumor tracking along them is less. Very often they come in contact, they just go up to the masseter and stop. Which means, of course, that you need to remove the masseter, but it usually doesn't transgress the masseter, so it doesn't come across the masseter. So when you have skin involvement, it's always more common to have skin involvement anteriorly, where you don't have as much of a barrier to soft tissue spread. The free edge of the cheek is quite thin. You don't have any barrier like the masseter. Very unlikely to have skin involvement posteriorly for the same reason. These soft tissue spaces are all quite contiguous. So you have the buccal space, you have the buccinator space shown here, you have the infratemporal fossa, you have the masticator space. So all of them are quite contiguous. They're not rigid spaces. It's not very easy to compartmentalize them. So what happens is, as the tumor grows, it goes from one space into the next. So why we need to understand this is that we need to try and do a compartmental clearance of each of these as the tumor gets bigger. So it's important that, for example, once the tumor enters the buccal space, you clear the buccal space completely. You don't want to leave behind any disease. You don't want to either occult or gross. And once you think of soft tissue involvement in these tumors, another reason why compartmental clearance involvement is important is because you can't really think of radial margins in terms of millimeters. So for mucosa and bone, we measure, 1 centimeter gross, 5 millimeters microscopic. You can't do that once you're in the soft tissue. So the easiest way and the most thorough way that we can do that is to look at these as contiguous compartments and decide how many compartments and which compartments we need to remove. So this is an example of a compartment resection, right? So this is a RMT, retromolar type 1 buccal cancer. Patient didn't have too much trismus. So this is the way that we resected it. Okay, so this is the maxilla, this is the mandible. So we've done a marginal mandibulectomy and an infrastructural maxillectomy. But look at the soft tissue involvement, right? So the soft tissue involvement, we've taken the entire masseter, right? We've taken most of the medial pterygoid, right? And this is the buccal mucosa. Look at the posterior base of the tumor. It was close to the skin, so we had no choice but to remove the skin. So basically, we have a contiguous compartment starting from the skin almost till the anterior tonsillar pillar. So we remove the whole thing en bloc. There's no chance of spillage. And we have a way for the pathologist to give us radial margins that are accurate. So now I'm not a fan personally of frozen sections. I don't think they're very useful here because they're difficult to sample. So basically we measure these mucosal margins, bone margins, and the deep margins quite clearly, and we know that we are far away from the tumor. So the compartment resection concept, of course, was proposed by Trivedi et al. And Ren et al. So two very different approaches to the same problem, both for advanced buccal cancers. They've done a lot of work on this. So some of the advantages of this compartment concept is there's less bleeding. So you stay on the outer aspect and devascularize the compartment as you go from outside to inside. You don't encounter the pterygoid venous plexus and other vascular structures that are likely to bleed. They also give us landmarks that give us a standardized approach to these cancers. So cutting through all of these muscles sometimes can be difficult. The only way you can tell where you are is from the direction of the muscle fibers, because the only fixed margins, landmarks that you have are the bony landmarks. They help maximize on-block clearance. And what I mean by that is if you take the medial pterygoid, for example, as far as you can at the pterygoid plate, then this is your posterior medial soft tissue margin. So if your tumor is sitting right here, you may have great margins all around here. But if your tumor is quite close, you've not taken your medial pterygoid, then the only margin that matters is this one, and it's going to be inadequate. Also, there's no additional loss of function. So when you remove the maxilla, when you remove the mandible, when you cut part of the masseter, when you detach the insertions or the origins of the medial and lateral pterygoid, you have lost masticatory function on that side of the mouth, right? So there's no advantage to leaving back some bit of soft tissue, some muscle fibers. You've de-innervated these areas, especially if you had to cut V3, V2 for your clearance. So there's no advantage really to leaving back some muscle fibers that are just going to fibrose and cause trismus. It's better to remove it clearly and reconstruct it adequately. The disadvantage is that you may resect more tissue than required. So these are some of the surgical considerations that I'm going to talk about briefly. So one of the most important surgical considerations is mouth opening. If your mouth opening is nil after general anesthesia, after induction, it's likely that you're going to need segmental mandibulectomy in at least part of the mandible. Otherwise, you can't get the mouth open. You won't be able to do a safe resection. Most importantly, post-operatively as well, the patient is not going to have any quality of life if they can't feed themselves or keep the mouth open. Another important thing is skin involvement. So these are where these tumors can be very, very deceptive. So in these gingival-buccal cell cancers, these extensive soft tissue alveolar cancers, very often what we find is the soft tissue involvement is subcutaneous. So the skin on the outer aspect of the mandible is extensive, right? So what can happen is the tumor will basically either break through the alveolar bone here, or it can spread along the gingiva, and you might have some induration here when you're seeing the patient. When you're examining, you might have some induration over the skin, and you think, okay, fine, that's close to the skin. Now, the problem is, if you look at your imaging, right, if you look at your buccinator muscle, for example, you look at your mentalis muscle, there is no way you can get an adequate margin by leaving only the skin behind, because the skin is very thin. If you resect these tumors inadequately, the patient is going to have a local recurrence. So very often we do have to sacrifice skin. It's very important before you put an incision on the patient to realize where you're going to sacrifice the skin. And why that is important is because of the vascularity of the skin and the lip. Now, this is the facial artery, as you all know. It basically comes up to the commissure, and then you have the superior and the inferior labial branches. Now, if you are going to do a midline lip split, which many people do, you are basically discontinuing the blood supply from the opposite lip. So all of the blood supply to this side of the face and the lip come from the facial, right? So if by some chance on the inner aspect of the buccal mucosa, if you are going till the commissure and you are going to sacrifice the facial, you can be 100% sure that this area of the lip and the skin will die, right? So a midline lip split is only suitable for patients in whom you are not going to resect anywhere near the commissure, and you're going to be able to leave the facial artery on the inner aspect of the cheek uninvolved. You can't touch it at all. You can't disrupt that blood supply. Otherwise, what happens is you do a midline lip split, you undermine your resection, comes up to the commissure, this part of the lip will die. Either it will die post-op or it won't bleed immediately, and you will end up sacrificing this unnecessarily. So whenever you're in any doubt, please split the angle. Okay, so there are some old concepts, like if you split the angle, you do an angle split, the patient will have oral incompetence, it's less cosmetic. Not true. I think you've done that for a huge series of patients. Nobody has any oral incompetence. You have to suture the commissure back carefully in layers. Also, it is much more cosmetic than having an incision on the midline, on the center of your face. Bone involvement, very, very important. Where you can get misled is if you don't see medullary spread. You cut through the bone and you see involvement within the medulla. That can be somewhere where you get misled. That can be a problem. Vascularity of the skin. So if you are taking a patch over the skin somewhere, right, it is important to incorporate that into your incision, and it's important to make sure that you don't devascularize the rest of the skin. Very, very important. Another important aspect is the facial nerve, right? So the facial nerve trunk lies within the parotid, as we all know. Very rare for a buccal cancer to involve the parotid gland, right? If it does, it's an extensive one. I've seen patients, of course, who have preoperative facial nerve involvement, facial palsy. lower motor neuron Hausmann-Brackman 6 or something like that, that is quite rare. Otherwise, most of them, the tumor goes up to the masseter, stop short of the parotid. So in those cases, do not go into the parotid, do not cut into the parotid. It's not required, oncologically not at all needed. If you are going to resect the distal branches of the facial nerve for an extensive buccal cancer, as we do most of the time, we'll split the lip. So as a result, you will resect the zygomatic branches, the marginal mandibular nerve. The only branch that's important is the eye branch, right? So the eye branch basically is represented by Pitanguy's line, right? Which is from the tragal cartilage to the lateral canthus. So you mark that out and do not raise your skin flap above that. So even if you are splitting the angle here, do not raise your cheek flap above here, right? Stay below the zygoma. So that way the patient doesn't have any injury to the eye branch. Very important, unnecessary morbidity otherwise. Finally, infratemporal fossa, very important. So you look at the masseter involvement, which is important, obviously. You can take the entire masseter down from the zygoma as a compartment for margin reasons. You look at the medial pterygoid involvement. Personally, I prefer to cut the medial and lateral pterygoid muscles last after tractioning down the whole specimen, because that is the margin which is most difficult to get. So you can actually take it down from the pterygoid plates. I would always suggest that you do a compartmental clearance. You start on the outside, which is the paratidomesenteric fascia and the masseter, and then you basically go around the infratemporal fossa in order to avoid bleeding and to give you good three-dimensional clearance. So I won't go too much into the specifications of that. Maybe we'll have a video demonstration or something on that subsequently. So margins, as we all know, we need at least 5 millimeters microscopic, both soft tissue and bone. There are some new papers that have come out from TMH that say that you need 1.5 centimeters of bone in advanced buccal and alveolar cancer. It is a small number of patients, relatively. It hasn't really been validated by anybody else. So interesting to note, not sure how much it applies today. It's important to maximize margins in these patients, right? Sometimes that means that we bevel the soft tissue. So basically, if you are taking skin, for example, you take a small island of skin and you bevel your soft tissue margins, right? You take down muscles at the origin, so you can take down the masseter from the zygomatic process. You take down the medial and lateral pterygoids from the pterygoid plates. That gives you a good amount of soft tissue around your tumor. Anyways, the muscle is non-functional. Also less chances of bleeding if you do it that way. Take skin margins when there's extensive soft tissue spread. So very often you will find a vague area of induration. So don't unnecessarily take huge margins in the skin. Some people say 2 centimeters. I don't really agree because we don't have any evidence to support that. If there is skin involvement, you need, again, 5 millimeters. That's the same as everything else. But you don't need to take huge skin margins prophylactically. So if there's no actual skin involvement, try to understand what the epicenter of tumor involvement is and bevel around that. Don't unnecessarily remove huge parts of the patient's face for no reason. Extent of resections. For a small buccal mucosa cancer, we can go up to the buccinator. For a large one that is going up to the alveolus, you may do a marginal if there is no bone involvement or just very early cortical bone involvement. Segmental, of course, if there's bone erosion, or paramandibular spread. Upper and lower gingival-buccal sulcus cancers, very often we end up doing a segmental mandibulectomy because of the soft tissue involvement. Marginal is relatively rare, only for early cancers. Similarly, infrastructure maxillectomy, you end up doing when there's tumor in the sulcus, because if that is the epicenter of the tumor, the upper gingival-buccal sulcus, the soft tissue margin required will mean that you have to cut the tissue in line with the bone, which means that an infrastructure is required. I'll explain what I mean by that in the next slide. For a retromolar trigone tumor, it's important to do at least a marginal mandibulectomy if the tumor is on the bone but not involving the bone. Generally, what we do is an L-shaped marginal mandibulectomy at the very least, where you start off at the coronoid process, take that down. That will also help with trismus. So very often we do that. Even if you're doing a marginal, we take down the coronoid process, detach the temporalis. That prevents trismus postoperatively. For a large retromolar trigone, a segmental mandibulectomy is the way to go. Infratemporal fossa is cleared if it's going along the medial pterygoid. So this is just an example of that. So this doesn't look like a very large tumor, but is sitting at the retromolar trigone and buccal mucosa confluence. So here we are taking bone only as a margin, right? So we take as little bone as possible, right? So we've literally taken only this much bone, just a small infrastructure maxillectomy. We've taken a marginal mandibulectomy here, right? This is the commissure. So very often we end up splitting the angle, because even if the tumor looks far away, by the time you measure a centimeter beyond where there's induration, you end up going till the lip. So if you go till the commissure here and split the midline lip split, this will be devascularized, the skin will die. So split the angle. The most important thing, arguably, in my opinion, is the soft tissue clearance. So these are actually tumors that require a lot of soft tissue clearance. It's not about the bone most of the time. That's what makes it a challenge. You look at the soft tissue clearance here, you have the medial pterygoid muscle, you have the masseter completely, right? And you have all of this soft tissue here. So this is the final resection picture. Part lower infratemporal fossa, marginal mandibulectomy, infrastructure maxillectomy. The only thing left on this flap is skin and nothing else. So you have basically from the skin to the tonsil is out. Yeah, so that was my presentation. I hope you liked it. Happy to take any questions.
Thank you so much, sir, for your insights on this very important topic of routes of spread of oral cancer and their management. It has been an absolute eye-opener, and we are sure our doctors must have learned a lot from this session. We will now take a couple of questions that we have received from our audience members. The first question that we have for you today is, what are your thoughts on metronomic cancer therapy?
So I think metronomic cancer therapy in oral cancer is of some value. So I guess there are two ways that we look at it. So metronomic chemotherapy traditionally is for patients who do not tolerate more intense chemotherapeutic regimens. It is somewhere in between best supportive care and palliative chemotherapy. So the advantage is if your patient has a poor performance status, they're nutritionally depleted, they're unlikely to withstand any intravenous chemotherapy, even something like cisplatin, then I think it's a reasonable option. I don't know how useful it is, to be honest. I think it's better that we give them some chemotherapeutic agents than nothing. But very often, these are the patients who we are unable to offer any other kind of treatment. So my suspicion is that some patients have tumors that are responsive to them. Some patients may have a dramatic response, which is great, but most won't have much of a response. So I think it is something that we should offer patients with the understanding that it may help some of them, but it may not help some of them.
Thank you. Thank you for your response, sir. The second question that we have for you is, what are some of the therapeutic options available in unresectable squamous cell carcinoma?
So I think that's a good question. I think it depends very much on what the performance status of the patient is. So if the patient is relatively young and fit, so when I use young, I mean physiologically, we don't really have an upper limit beyond which we don't treat patients anymore. If you have a fit patient who is willing to undergo treatment, what I would offer them is induction chemotherapy. Induction chemotherapy typically is with 2 drugs or with 3 drugs, depending on how fit the patient is. If the patient is very fit, you can give them 3 drugs. We use the TPF regimen. Otherwise, you use the 2-drug regimen, and we reassess them. Now, if they respond well and they are now resectable, great. Then we should resect them and give them adjuvant therapy. But if they do not respond well, if the tumor doesn't shrink, then it's likely that they are best suited for palliative care. or you can give them radical chemoradiotherapy. So again, it's a bit of a broad question that you asked. A couple of pointers here. Number one, if you think that the patient has a very extensive disease that even if it shrinks, you're not going to be able to operate, it probably doesn't make any sense to give them induction chemotherapy. We should know that the response rates with induction chemo, even in the best settings, are only around 43%. So if you have a very advanced disease patient with intracranial involvement, those kind of things, just straight away give them palliative therapy. Save their time, effort. If the patient wants radical treatment and you are hopeful that if the tumor shrinks that you can do a good surgical clearance, then give them induction chemo. As of now, there are some studies looking at immunotherapy, but all of this is within a trial setting. We honestly can't extrapolate any of that. There are multiple ongoing clinical trials. We have to wait and see what they say.
Thank you, sir. The third question that we have is there any age limit for patients recommended for full dose CCRT in head and neck cancer?
So we do obviously have Pignon's meta-analysis that says that if you're over 70, giving you chemotherapy along with radiotherapy is not likely to be of much benefit. The absolute survival benefit is low. So what that means is it's based, I guess, on your life expectancy, number one. How long are you likely to live beyond the age of 70? And number two, how severe are the chemotherapy complications and how are they likely to impact you? Because as we all know, they are not without risk, and patients can succumb to concurrent chemoradiotherapy related complications. It is rare, but it does happen. So the general answer to that question is 70, but I think we are pushing that nowadays. Patients over 70 sometimes, if carefully selected, get chemoradiotherapy. But it's important to realize that the mainstay of treatment is the radiotherapy, not the chemo. So the chemotherapy gives you about a 10% benefit over radiotherapy alone. But if the chemotherapy adds so much morbidity that they're unable to complete the radiotherapy, then you've kind of lost the plot there. So if you think that the patient is unlikely to take chemo, then give them radical radiotherapy. It is good enough for most patients. You may not have that last few percentage point of benefit, but the main thing is your concurrent radiotherapy and not your chemotherapy.
And the final question that we have for you for the day before we wrap up this session is bilateral neck dissection required in case of ulcero-infiltrative, not proliferative, CA tongue or cancer of the tongue involving lateral border but not crossing the midline?
Interesting question. So I think this is something that not many people would agree with. There are people who do bilateral neck dissection in cases that are also ulcero-infiltrative. So the data we have for this paper is Kowalski's paper, which looked at the causes for contralateral nodal spread for a lateralized oral cancer. Obviously, if it is a cancer that is in the midline or spreading across, we know that it has a propensity to go to the opposite side. So for a tongue cancer, we know that if it's crossing the midline, or if it's involving the floor of mouth, or it is ipsilateral node positive, it's more likely to have contralateral node involvement. But if it's an ulcero-infiltrative growth that's just going up to the floor of mouth, personally, I wouldn't do that. If it's unlikely that the patient has occult nodal disease on the opposite side, giving them elective radiotherapy to that opposite side is an option. I think that is something that many surgeons would consider. If the patient is going to get radiotherapy, they can get a prophylactic dose to the opposite side. It's going to be less morbid than doing a neck dissection on them. So again, unfortunately, it's a very good question. I don't have an absolute answer. It depends very much on the patient. But I wouldn't do a contralateral elective neck dissection for every single patient. I don't think we have evidence to support that.
Thank you. Thank you so much, Dr. Subramaniam, for all your responses and for a very insightful and informative presentation. We are sure our audience members must have learned a great deal and they must have received a lot of clinically relevant information from your session. We would like to thank you for making time for this presentation and being a part of this special day webinar. We look forward to interacting with you in the near future very soon. To all our audience members, thank you so much for your active and your enthusiastic participation in this webinar. We will be back with another brand new session of Master Series on next Wednesday, 3 p.m. Till then, take care and happy Doc